I think what's so exciting about this opportunity for the Northeast LHIN is that you're launching on an entirely new way to provide care. Introducing electronic systems, advanced electronic systems to healthcare enables a whole new way of improving quality, safety, and value. To the point that actually systems become more than just a passive conduit for data like lab values or radiology results, but actually become a partner in helping clinicians make better decisions with their patients at the point of care. Being able to actually take the best evidence and best practices from the literature, pull it forward at the time that you're making a decision, and then actually help that to be part of the decision right when you're with the patient. So it enables us to do so much more and actually also do it with less, because now we can choose more wisely in the investigations and management that we undertake with our patients, so that we're ordering just the best tests and the most important medications and not just everything under the sun. When we talk about embarking on clinical standardization, it sounds like a whole lot of work and it sounds pretty daunting, but the benefits downstream are huge for patients and providers. Because when we all start to speak the same language, when we're taking out variations in care that may disadvantage our patients, and also using the same data structures across one hospital to another, or in primary care to hospital-based care, then we can share data across the continuum. The data follows the patient. Rather than having to order the same tests twice at two different hospitals because we can't get results, we can actually see in real time what has already been done for that patient and pick up where we last left off. That's what our patients expect and deserve. Also, because we're standardizing care, we're now able to share the burden of building and maintaining these systems. Because advanced electronic systems are not just about showing results. We now have a large volume of clinical data in the system. We have clinical documentation templates, and we have order sets, and that content needs to be kept up to date. If every hospital is trying to do that on their own, it's simply too much burden for each individual hospital to do. So by sharing the clinical data structures, we can also share the work. It means we can centralize, for example, all of the content around patients with respiratory disease. And we can have one group of experts across the hospitals sharing their knowledge and expertise, building in the evidence, and then pushing that out to all of the different hospitals. I think what this new project means for our clinicians, it's a huge opportunity for them because the systems are now about the direct interface of how we provide care. It's building best practice and best evidence into the work that we do every day. And the people who have the most expertise about how care should best be provided are our frontline clinicians. It's not people who are working in a back room as a technical build or an administrator. It's the people who actually touch patients every day. And so it's incumbent upon all clinicians to be involved in this project, to make their mark, to give their approval and review the content so that they know that it's going to meet the needs of them as they do their work every day, but also to provide that best care for their patients.